pyloric stenosis. This condition occurs in young infants and presents with projectile emesis due to gastric outlet obstruction. The obstruction is caused by thickening and elongation of the pylorus. The pylorus is the most distal region of the stomach, opening into the duodenum. In pyloric stenosis, the circular layer of smooth muscle surrounding the pylorus becomes thickened after birth. This is due to hypertrophy and hyperplasia of the muscle cells. The thickened muscle blocks the passage of milk into the duodenum, causing projectile emesis. Because the obstruction is proximal to the bile duct, the emesis is non-bilious, meaning it doesn't appear bright yellow or green. The etiology is likely multifactorial, involving the interplay of genetic factors such as male sex or a positive family history with environmental exposures such as exposure to macrolide antibiotics. Patients typically present between 3 to 6 weeks of age with projectile non-bilious emesis that occurs immediately after feeding. After emesis, they are eager to refeed. Physical examination classically shows a palpable olive-shaped mass in the right upper quadrant of the abdomen due to the thickened muscle. This finding is pathognomonic of pyloric stenosis. Peristaltic waves may also be seen as muscle contractions attempt to move gastric contents beyond the obstruction. Patients with protracted vomiting may have weight loss and signs of dehydration, including a sunken fontanelle, dry mucous membranes, and decreased urine output. The diagnosis can be confirmed with abdominal ultrasound, which shows a thickened, elongated pyloric muscle. Laboratory tests can be used to assess dehydration and electrolyte abnormalities. In patients with prolonged vomiting, labs characteristically show hypochloremic, hypokalemic metabolic alkalosis. This is because persistent vomiting causes significant gastric hydrochloric acid loss, which leads to metabolic alkalosis and a loss of chloride. It also causes significant fluid loss, resulting in decreased renal perfusion and activation of the renin-angiotensin-aldosterone system. This increases bicarbonate reabsorption and hydrogen ion secretion, further contributing to metabolic alkalosis. Aldosterone also causes potassium secretion in the collecting duct, resulting in hypokalemia. Labs may also show unconjugated hyperbilirubinemia. This is due to dehydration, which increases enterohepatic circulation of bilirubin. The definitive treatment involves pyloromyotomy. In this surgery, a longitudinal incision is made in the hypertrophic pyloric muscle, which relieves the obstruction and allows food to pass into the duodenum. Patients with dehydration or electrolyte abnormalities should receive intravenous hydration and electrolyte repletion before surgery. Overall, the prognosis is excellent, and the majority of patients resume normal feeding within hours of the operation. To sum up, here are the key points to remember. Infantile hypertrophic pyloric stenosis is characterized by thickening and elongation of the pylorus. This causes gastric outlet obstruction, leading to postprandial projectile non-bilious emesis between 3 to 6 weeks of age. Physical examination classically shows a palpable olive-shaped abdominal mass. Peristaltic waves may also be seen. The etiology likely involves the interplay of genetic factors with environmental exposures, such as exposure to macrolide antibiotics. The diagnosis can be confirmed with abdominal ultrasound. In patients with prolonged vomiting, laboratory tests classically show hypochloremic, hypokalemic metabolic alkalosis. The definitive treatment involves pyloromyotomy.